Today I have the pleasure of introducing Dr. Jane Chung. Dr. Chung is a member of our sports medicine team here at Texas Scottish Rite. She's board certified in pediatrics and sports medicine, and she specializes in non-operative management of musculoskeletal injuries in young athletes. With a particular interest in concussion management, return to play decisions, and problems affecting the female athlete, Dr. Chung earned her medical degree from St. George's University. She completed her pediatric residency at Louisiana State University and her sports medicine fellowship at Case Medical Center through Rainbow Babies and Children's Hospital in Cleveland, Ohio. Today she's going to be discussing with us some hot topics in sports medicine, and without further ado, here's Dr. Chung.
All right, good morning, everybody. Thank you for joining us bright and early. Before I get started, I want to acknowledge all the physical therapists out there. This month is Physical Therapy Month, and so thank you to all of you wonderful physical therapists out there in our audience. We truly appreciate all the hard work and for working with our athletes every step of the way in their recovery, so thank you very much. So this morning we're going to talk about hot topics in sports medicine, some of the current modalities and trends out there. I have no financial disclosures. So all of us encounter, whether they walk into our sports medicine clinic or pediatric office, in our training room, or in your clinic for physical therapy, athletes who come in injured and wanting to get better, and they usually want to get better fast, right? And so current trends are constantly changing, so we're just going to hit upon few hot topics in terms of modalities and trends in sports medicine. So I'll be touching upon PRP, also called platelet-rich plasma, what's the evidence in current applications, blood flow restriction and what type of technique this is, whole body cryotherapy, what is it and does it really work, and last but not least, high intensity interval training, also known as HIIT, and what are the pros and cons, and is it really for everyone? So there always seems to be some new innovative fitness trend that eventually becomes the next thing that everyone wants to try, right? So whether it's the Peloton providing live stream fitness classes into your living room, or the next new wearable technology, or a new fitness class, keeping up with fitness and sports trends kind of is like keeping up with modern day fashion, right? And trying to keep up with what's hot on the runway. So let's dive into platelet-rich plasma. So what is this, right? So just a brief overview. So PRP falls under the umbrella of regenerative medicine, right? And so blood is drawn from a patient and the sample is spun down in a centrifuge machine, which you see on the top right corner there. And what it does is it separates red blood cell from the blood that's rich in platelets. And we take the blood that's rich in platelets and we inject it into the area or the region of injury. So what is the big deal about the platelet that's rich in plasma? Well, there are high concentrations of cytokines and growth factors such as TGF-beta that release healing properties to augment the healing process. The injection can be either delivered blindly or through ultrasound usage, and there are still many gaps that we don't know as to what's the perfect volume to inject, the frequency, how often should we inject these, and post-injection care really are not truly determined yet. So PRP kind of hit the market hot when a lot of the celebrity athletes have been known and discussed to travel out of the country when it first came out to receive treatments, right? So Kobe Bryant used to travel to Germany to get PRP into his knee back in the day. Tiger Woods has been known to receive stem cell treatments for his lower back issues. And so its usage is wide, oftentimes used for chronic tendon injuries, such as lateral epicondylitis, patellar tendonitis, Achilles issues, acute muscle injuries, which we will talk about shortly. It can be used intraoperatively and postoperatively as well, and frequently is used to treat degenerative joint disease, particularly knee osteoarthritis. So as clinicians and healthcare providers, we like to practice evidence-based medicine. So we're just going to talk about what's out there in literature so that we as healthcare providers and clinicians can provide evidence-based medicine advice and counsel our patients when we are talking about these modalities. And so hamstring injuries are one of the most common sports injuries that we see, and they can cause significant time loss away from sports. So that's why a lot of the literature that has looked at PRP, they pretty much looked at acute muscle injuries, particularly of the hamstring muscle. So this first landmark study that was published in 2014 by Hamid and his group, they looked to investigate the effect of a single PRP injection in the treatment of grade 2 hamstring injuries. Their patients were 18 years and older. They had a sample size of 28 patients. 14 were in the control group and 14 received the PRP injection. They all presented within 7 days of their injury, so it was an acute injury, and they were randomized into the PRP group with intense rehab or just the control group, which would just receive intense rehab alone. And what they found was that the PRP group achieved full recovery significantly earlier than the control group, and that the mean return to play was about 42.5 days in the control group compared to about 26.7 days in the PRP group. And so throughout the study, the PRP group also had significantly lower pain severity scores as well too. And so this study concluded that a single autologous PRP injection combined with a rehabilitation program was significantly more effective in treating hamstring injuries than rehab alone. Another study that soon followed in the Dutch group in 2015, it was a better study. So it was randomized, double-blind, placebo-controlled trial that was conducted in 3 separate sites. And they had a sample size that was larger, so 80 competitive and recreational athletes with acute hamstring injuries. And these were diagnosed and confirmed via MRI. And they were to receive intramuscular PRP injections versus a isotonic saline or salt solution in the placebo group. So their patients, again, were 18 years or older. They had 41 patients in the PRP group and about 39 who received the saline or the salt solution, and that was their placebo group. And the first injection was within 5 days, and then they received a second injection after about a week within the first injection. And so this study showed that there really was no benefit in those patients who received intramuscular PRP injections compared to the placebo group in terms of recovery time. And at the 26-week follow-up, there really was no significant difference in overall hamstring outcome scores as well, looking at symptoms, soreness, pain, and functionality in sports. And the PRP group and the placebo group both sustained a re-injury rate about 30% at their 1-year follow-up period. So again, pretty similar. So this chart just shows the 2 landmark studies that kind of launched off the popularity of PRP. The first one with Wernick and his group that showed that PRP really didn't have any significant influence in return to play, whereas Hamid and his group showed that PRP did have a significant influence in getting athletes back to sport quicker. So when looking at platelet-rich plasma and going back to sports, another study was done in 2015, published in BJSM, and they wanted to look at the efficacy of a single PRP injection in reducing return to play duration in male athletes after, again, an acute hamstring injury. I told you hamstring injuries were going to be studied a lot at. So this had a sample size of 90 athletes, and these athletes were also confirmed via MRI either as a grade 1 or 2 hamstring injury. This study had 3 arms. So the group that received PRP, a group that received platelet-poor plasma, so plasma that didn't really have much platelets, and a group that didn't receive any injection at all. And all of these groups did receive a combination of intense rehab program simultaneously as well. And so they show that there really was no benefit from a single PRP injection in combination with rehab versus those athletes who received just intense rehab alone after sustaining an acute MRI positive hamstring injury. But they did show that a PRP injection in combination with rehab reduced the return to sport duration when compared to a single platelet-poor plasma injection in rehab. This recent study wanted to look at it was a systemic review and a meta-analysis looking at the use of PRP and does it really affect or have an influence in pain. And so the objectives for the study were, does PRP reduce patient-reported pain in musculoskeletal conditions? And do the characteristics of PRP influence its treatment effect? So they looked at 78 randomized controlled trials, so about 5,000 patients were included in the study. And this was just released from Sports Health not too long ago. And so what they found was that there was a reduction in pain associated with PRP at 3 months, and it was sustained up to a year. But however, this was low to moderate quality evidence that supports a reduction in pain, mostly for lateral epicondylitis, so for tennis elbow, and for knee osteoarthritis, or for degenerative joint disease in the knee. And they also found that PRP characteristics really didn't influence the results. And so they concluded that PRP does lead to a reduction in pain in some of the conditions as discussed above. However, evidence for clinically significant efficacy is still very limited. So some take-home points for PRP would be there really is no evidence to date that PRP in acute muscle injuries is superior than placebo alone or just rehabilitation alone, and that it can be associated with a reduction in patient-reported pain for up to 1 year for certain conditions, like we talked about for knee OA or for lateral epicondylitis. And despite its widespread usage, little really is known on the benefits of therapy on the musculoskeletal system. Let's talk about blood flow restriction technique. So a little bit of background. So we know that strength training really is an important part of rehab and for getting athletes back into recovery. So traditional, it's about 60 to 70% of 1 repetition maximum. Over the past decade, research has been starting to show that light load strength training in combination with blood flow restriction may lead to significant muscle strength and size in healthy individuals. And we know that heavy load strength training is not possible for some of our populations that we may treat, particularly those who may have just had surgery, those with severe patellofemoral pain or other musculoskeletal impairment, or elderly patients who have degenerative joint disease. So what really is this, right? So it is a technique that induces blood flow restriction. So a blood pressure cuff, I have a picture in the next slide, or a pneumatic cuff is placed proximally to the limb, whether it's an upper extremity issue or a lower extremity issue that you're trying to focus, such as the knee. And it's a training modality that uses partial vascular occlusion, typically restricting venous outflow from the muscle, while these patients are performing exercises at lower loads to improve muscle strength, size, and endurance. And so the low load resistance is about 20 to 30% of 1 repetition maximum, compared to heavy load, which is, as stated earlier, 60 to 70% of 1 repetition maximum normally. So this is a picture of an athlete. You can see he is rehabbing his knee, but the pneumatic cuff is placed right in the quad region, and it is inflated to reduce partial blood flow restriction. And they are able to perform leg extensions, leg presses, reverse leg presses in a seated position. So think of it kind of as like a tourniquet in place while the athlete is performing these low load exercises. And it really gained attention in the community as lower loads were used during therapy to lead to strength gains and possibly accelerating rehab and providing faster return to sports and activities for patients. So let's look at some of the evidence that's out there. So in 2017, this group published a literature search. They looked at 22 studies, included studies using blood flow restriction after a ACL reconstruction, knee OA, adults with sarcopenia, and they compared low-load training versus low-load BFR training, and they found that low-load BFR training is more effective and tolerable, and therefore could be a potential rehabilitation tool when treating patients. But it was found not to be as effective as compared to heavy-load training. And again, most of these studies were done in the elderly population. Big question is this safe, right? You're kind of restricting blood flow. And so is there increased risk of blood clots, muscle damage? Will it negatively affect the cardiovascular system? There have been a few case reports that have reported rhabdo, delayed onset muscle soreness, but these were likely independent of the blood flow restriction technique and simply just responses to individuals being unaccustomed to exercise is what the studies have reported. Adverse effects have largely been unfounded in these studies. contraindications for blood flow restriction technique would be if a patient has fracture or if there's a tumor in that area, any kind of infection. Also, you want to be careful with those patients with hypertension, history of DVT or clotting. Pregnant patients, probably not the best for them. So some some contraindications to kind of keep in mind. So let's look at some of the studies done using blood flow restriction technique after an ACL reconstruction. So Oda and his group back in 2003 were kind of the pioneers using BFR. So they had a sample size of 44 patients, average age was 29, and they had pre-surgery versus 16 weeks post-op patients. And they found that those patients who received blood flow restriction technique had significant increase in their muscle strength compared to those who did not receive blood flow restriction technique during their post-op rehab. They also took small sample sizes of the muscle fibers, and they found that the short diameters of type 1 and type 2 fibers of the vastus lateralis in the quad was larger for the BFR group, but the differences were not really too significant. And so this really was the first study to show that low load or light load BFR training may be effective for early muscular training in those patients after an ACL reconstruction. Some other studies followed through, and so Takarada and his group in 2000 had a small sample size of 16, and they show that occlusive stimulus, or BFR, postoperative in days 3 to 14 decreases post-op disuse atrophy of the quad muscles, up to 50%. Iverson and his group recently in 2016 randomized his patients into the BFR group versus a control group that just had a standard exercise protocol without occlusion stimulus. And he found that there really was no significant difference between the BFR group and the control group in terms of atrophy of the quad muscles. So not a lot of studies done, or none done in the pediatric group, so more studies looking at the pediatric population really are needed, as these were mostly done in adults. What about BFR for patellofemoral pain? Many of us see patients with patellofemoral pain, and many of us treat patients with patellofemoral pain. And so this group randomized a control study that was nicely done in Australia, had 69 patients, and they all had patellofemoral pain. They had 34 in the standard group and 35 patients who received light load BFR for about 8 weeks, and they all had a standardized quad strengthening program. And what they found was that those patients in the light load BFR produced greater reduction in pain with daily activity compared to those who just received standard quad strengthening exercises. And in particular, they found that there was a subgroup with painful resisted knee extension had larger improvements in quad strength from the BFR group, but no real change in pain status. And so this study really showed that BFR training may perhaps be a good alternative to standardized quad strengthening, particularly for those patients with patellofemoral pain who may have poor tolerance to heavy resistance training secondary to their pain. So this chart kind of shows changes in knee extension torque measured in newtons per meters by group and their pain response in resisted knee extension. And I circled and put a star by the BFR group who had pain with resisted knee extension. They actually showed the greatest increase in quad strength. What about BFR use after knee scopes or knee arthroscopy? This group showed that, that 17 patients in their groups, they looked at non-reconstructive knee arthroscopy and started BFR 20 days from day of surgery. And they compared versus those patients who were in the control group who received just conventional rehabilitation therapy. And they found significant increases in thigh girth and physical outcome measures in the blood flow restriction group. And so they concluded that BFR may perhaps be an effective intervention in knee arthroscopy. And again, no adverse events occurred in the study, so showing that it's pretty safe to perform in patients. So looking at all of this, where do we currently stand? Recently, 2019, the Systemic Lit Review was published by Weston and her group, and it's a level 2 study, and they looked at BFR technique used after ACL reconstructions, knee arthroscopy, patellofemoral pain, degenerative knee osteoarthritis, and 6 of the 7 studies that measured quad strength reported statistically significant improvements after training, and no complications were reported to training. And so from this really limited data, it does show us that light-load BFR training is safe and potentially effective in improving quad muscle strength in patients with weakness and atrophy related to knee pathology. So in summary, clinical applications for BFR training in patients with musculoskeletal conditions truly are vast, and sky seems to be the limit for this use. Further studies are needed to study the efficacy and the safety of blood flow restriction technique, both operatively and non-operatively in orthopedic conditions, and there really is limited data available in the pediatric population. Cryotherapy. So what is cryotherapy? Well, a lot of athletes certainly are using it. Floyd Mayweather here in the whole body cryo chamber in 2015. A lot of celebrities and high-profile athletes certainly have been captured using cryotherapy. So what are some of its claims, right? So it provides muscle and joint relief, they say, can help with a slew of medical conditions, even Alzheimer's, multiple sclerosis, rheumatoid arthritis, OA, migraines, chronic pain, fibromyalgia, asthma even. Has been claimed to even help with weight loss, younger, rejuvenated-looking skin, and even improving mood and energy. So we know that applying cold to an area of injury is very effective, right? But the benefits of doing that to your whole body at a single moment is less established. So who came up with this idea and what are its origins? So Professor Toshiro in Japan, who treats rheumatoid arthritis patients, had a personal observation with his rheumatoid arthritis patients. So he found that in combination of cold and physical exercise was found to be beneficial for his rheumatoid arthritis patients, particularly after they came back from the cold mountains after their winter holidays. And so they've reported that, exposing their whole body to cold temperature really relieved their rheumatoid arthritis symptoms. And so this was how whole body cryo was introduced into clinical practice. In sports medicine, we use it, thinking that it may enhance recovery after intense workouts or injuries, counteracting the inflammatory symptoms from overuse, post-traumatic recovery, decreasing pain, and perhaps improving performance. So what exactly is this, right? So it's a brief full body exposure to dry air at cryogenic temperatures ranging from about -10 to -140 degrees Celsius, or from -160 to about -220 degrees Fahrenheit. And you're submerged in it for about 2 to 4 minutes in a chamber that's cooled by liquid nitrogen that kind of fluxes up and down in the chambers, in pipes in this chamber. And so that's how cryo is done. Some important information: it is not FDA regulated, and it is not cleared or approved by the FDA as a safe and effective device to treat medical conditions, right? Some of you may have heard the news back in 2015 when a 24-year-old cryotherapy spa employee died after stepping into the cryo chamber unsupervised and literally froze to death. There have also been some lawsuit files where cryo was offered at the gym, and women were complaining that it left them with permanent scarring in their skin. Definitely not FDA approved. The patient goes in, they are minimally dressed, so they're typically wearing a robe, their extremities are covered, so they'll be wearing gloves or mittens and socks in their feet. A skilled personnel should be controlling the procedure. Patients may leave the chamber at any time during their therapy. So if they're not able to tolerate it, or if it's too cold for them, they may leave the chamber at any time. Currently, some of the contraindications for cryotherapy include those with Raynaud's disease, cryoglobulinemia, those who have cachexia, certain cardiovascular diseases, and most importantly, children under the age of 18 do need parental consent to do it. And one important thing to note is that the head needs to be above the chamber. Oops, sorry. I had a 12-year-old patient who came in and said she received cryo, but slipped and fell and got a concussion, but she was only about yay tall and her head was not above the chamber, so her entire body was in the chamber. So you really want to be careful and make sure you go to a facility if your patients, say they're going to go get cryotherapy at a facility where they, really know what they're doing and it's well supervised. All right, so its effectiveness. Anti-inflammatory and analgesic effects and effectiveness of this treatment are still highly debated, and there's lots of contrasting data that's out there. Bottoni and his group looked at fibromyalgia patients, and they said those patients with fibromyalgia who received whole body cryo demonstrated clinically larger improvements in their overall quality of life and ability to perform everyday activities of living. So that's fantastic. What about whole body cryo and its effects on exercises, right? So we all treat athletes. Does it really have an effect when athletes say after an intense workout that they're going to jump into the cryo chamber? Well, this study that was released in 2017 did a lit search using 6 databases, and they came up with 16 articles. 10 of them were laboratory controlled studies using cryo, and 6 were assessed during training periods, so it was clinical application. And 10 of the articles were done in highly trained athletes where they were recruited. 6 of the articles were just done in healthy, physically active participants. And so the largest N for these studies were found to only be 26 in their sample size with a mean N of about 13. So these are really, really small studies that we're looking at. And so what they found was that overall, both the lab-controlled and the applied setting whole body cryo may be successful in enhancing mean voluntary contraction, returning athletes to pre-exercise strength, perhaps at a faster rate than the control conditions. They also inferred that whole body cryotherapy may dampen inflammatory cytokine response, so suppressing creatine kinase, cortisone levels, and other inflammatory markers, possibly leading to a less secondary tissue damage, perhaps accelerating recovery in athletes. Is it dose dependent? We're not sure, but they did show that multiple exposures of 3+ sessions of 3 minutes minimum immediately after and in 2 to 3 days post-exercise were found to have the most consistent results. And so kind of looking at it in general, there really is a lack of ability to blind for recovery treatment using whole body cryotherapy, and so we're not really able to eliminate potential placebo effects as well, right? These study designs varied vastly, and it was really difficult to make inferences across these studies. And there's a lack of standardized protocols for temperature, timing, and frequency. And so future larger studies would be fantastic and are needed to determine the impact of time course effects of whole body cryotherapy on muscle recovery after mechanical overload in the athletic population. Let's talk about high intensity interval training. How many of you in the audience have heard about this? Yeah, so it's one of the hot topics and hot trends, right, in fitness. So is it really for everyone? What it is repeated bouts of really high intensity effort followed by a brief period of recovery time, and these recovery times may vary. Intense work period can range anywhere from 5 seconds up to 8 minutes, and it's done at about 80 to 95% of estimated heart rate maximum. Recovery periods can last as long as the work periods or less, and it typically is at 40 to 50% of the estimated maximal heart rate. So maximal heart rate is the highest heart rate that you can attain during exercise, and it's easily calculated as 220 minus your age. These workouts can range anywhere from 20 minutes to 60 minutes, or as short as you would like. And a good range for how do you know if you're working out 80 to 95% of your heart rate maximum? A good subjective indicator is you should feel like you're working out or exercising hard to very hard. So pretty much having difficulty carrying out a conversation while you're intensely working out. What are some of the benefits of this high intensity interval training, right? It's known to be great for aerobic and anaerobic fitness, has been associated with improving blood pressure, improving your cardiovascular health, improving cholesterol profiles, losing abdominal and body fat while maintaining muscle mass, has been shown to improve insulin sensitivity. And there also has been some reports and studies coming out that perhaps it may improve brain health as well. So I thought this study was very interesting. It was just published in a study done out in Australia in 2019. So Klein and his group looked at 11 men who were on average 25 years of age and 10 older men who were about 69 years of age on average. And they performed 3 exercise tests. So one was a high-intensity interval training on the exercise bike, where they had 3-minute period, 85% of their heart rate maximum, and they had 1-minute rest or passive period. And the other training that they did was continuous riding for about 10 minutes with 10 minutes of rest followed. And then another training that they did was 10 sets of 1-minute intervals of 60% maximal wattage on the bike with 1-minute rest. And they were looking at middle cerebral artery blood velocity in the brain, end-tidal CO2, and blood pressure. And what they showed from their small study was that middle cerebral artery blood velocity increased during continuous compared to interval exercise in young patients, but not in the old patients. And so they concluded that interval exercise may be an effective alternative to promoting acute increase in cerebral blood flow velocity in the older patients who may have difficulty sustaining continuous exercise. And we all know that increased cerebral blood flow, has been associated with helping with Alzheimer's and preventing other neurodegenerative diseases. So I thought it was a very, very interesting study that, HIIT may perhaps have some benefit in brain health as well too. What's so great about this is that it can be easily modified to all fitness levels, right? And for those patients with special needs. So those patients who may have diabetes or have obesity, it can be modified to fit them. And it can be performed on all types, right? So it can be done on the exercise bike, it can be done in the pool, running and walking, on the elliptical. So a variety of exercise modes that HIIT can be modified for. It's also time efficient. All of us can't find enough hours in the day to do everything that we want to do. And so it provides similar benefits as to continuous endurance workouts, but in a shorter, compacted period of time. And last but not least, but most importantly, it burns more calories as well too, especially post-workout. And this is due to increase in what we call EPOC, or its excess post-exercise oxygen consumption, where during about that 2-hour period after exercise, the body is trying to restore itself to pre-exercise levels. So it's burning more calories as it tries to restore itself back to pre-level exercises. Some of the common HIIT programs, right? So I just wanted to list them here. 1-to-1 ratio of exercise to recovery. So for example, 3-minute hard sprinting and 3-minute recovery where you're either walking or jogging at 40 to 50% of your heart rate maximum. The sprint interval training method is also very popular too, where you go all on out and you sprint for about 30 seconds, followed by a 4 to 5 minute recovery. And you do this for about 3 to 5 reps. I don't know if some of you may have noted when you go to the gym, all of a sudden the treadmill next to you, the person is hauling and sprinting all on out for 30 seconds to a minute, and then they slow way back down, and so they're just walking. So that's their recovery period that they're doing. The 7-minute workout, I personally like to do. It's really easy and it's only 7 minutes. It's 12 exercises for 30 seconds and 10-second rest in between. So each exercise you do for 30 seconds. So jumping jacks, followed by wall sit-ups, and then push-ups, abdominal crunch, step up onto chair, squat, triceps dip on chair, plank, high knees, lunge, push-up and rotation, side plank. And so you do all of these all out for 30 seconds, and you have a 10-second rest period in between them. It's a really, really good workout. And again, it's only 7 minutes, which is fantastic. What are some of the safety concerns? Well, we know that if the patient is living a sedentary lifestyle to begin with, or they're really not physically active, or they have obesity, hypertension, diabetes, I recommend getting medical clearance from their physician prior to starting a HIIT program. It's probably most appropriate that they get checked out first. Overtraining is also another safety concern. Exertional rhabdomyolysis, right? Sudden increase in muscle exercising. And then prior to starting a HIIT program, the patient really should have developed a fundamental level of fitness, right? You don't want to have someone who's a couch potato all of a sudden get up and engage themselves in a HIIT program. So I always say you should have a base fitness, right? So participating in some aerobic exercise at least 3 to 5 times a week for about 20 to 60 minutes before embarking on a high-intensity interval training program. How many times a week can you train, right? So these workouts are definitely more exhaustive than steady-state endurance workouts, and so it requires a longer recovery period. So it's recommended that you start off about once a week, then progress to twice a week. What about high-intensity interval training for adolescents and children, right? So there's a sparsity of data and literature out there, but Eddles and his group looked in 2017, did a literature search, and they found 13 studies that were done in healthy kids 5 to 18 years of age. And they found that high-intensity interval training can improve certain cardiovascular conditions and parameters in children, like improving blood glucose, improving the cholesterol profiles, improving triglyceride levels, and improving insulin hypersensitivity. And so it has been shown to have some positive benefits. Evidence supporting overall effectiveness of high-intensity interval training in health outcomes is still unclear. And the optimal exercise duration, how long should the rest interval be, all of this really remains unclear, again, due to the paucity of literature. So this group, and this is a fresh, hot off the press, it's an EPUB that will be coming out in the International Journal of Sports Medicine. They looked at the effects of various work-to-rest ratios of high-intensity interval training on athletic performance in athletes. And this study looked at 47 male Taekwondo athletes who were about 15 to 18 years of age. And they wanted to look at the effect of high-intensity interval training with different rest-to-work ratios and athletic performance on these young athletes. And so they randomly assigned these athletes into 3 types of high-intensity interval training groups. And they also had a control group as well. So each group performed about 6 to 8 bouts of high-intensity training, and the work-to-rest ratio was either 1 to 2, 1 to 4, 1 to 8, and you had the control group, which only performed Taekwondo training programs. And so they all participated in this 10 sessions over a 4-week period. And what they found was that the maximal oxygen consumption, or VO2 max interval, significantly improved in all of the high-intensity interval training groups. And they also found that the group that had the 1 to 4 work ratio, where they worked for 30 seconds and they rested or recovered for 120 seconds, that group showed most effective for improving anaerobic capacity and aerobic capacity in adolescent Taekwondo athletes. And so very exciting study. I think more certainly to come, and to see, can this be applied into some of our athletes in terms of, training, improving performance, and such. So this is just a glimpse capture of all of the hot topics and current trends that I thought were important for all of us to know, so that we can be educated with evidence-based medicine and provide good advice, and have some armamentary so we can counsel our patients and parents when they ask us about these hot modalities. And so thank you very much for all your attention. Thank you for everyone joining online as well too, and I think we are going to be open for questions at this time.
I've got a quick question for you, Jane. When we're talking about PRP and looking at all of those studies on hamstring injuries and the acuity of them, do you know if there's any value to repeat injections of PRP, or were most of these single shot injections? I know that sometimes can be still variable, and we don't really understand all of that, if there's any value in having more than one injection.
Mm-hmm. Great question. So when I was doing the literature search, there was one study that I showed. They did 2 injections, one within 5 days of the acute injury and a second injection that was done 5 to 7 days after the first injection, and they really didn't show that there was any benefit to getting repeated injections. And as far as I know, to date in literature, there really isn't any data showing that repeat injections are maybe more beneficial than having just a single autologous injection. Yeah.
Yeah, we still wonder a lot about that in the cartilage world, especially in kids, is whether one injection is fine to help cartilage heal, or if we need more than one injection.
Right, and I think, it's a really exciting area that I feel like still needs to be studied, because in the pediatric population, there really isn't any good randomized controlled trial that's been done looking at the younger patient. And I think, can we use it for maybe patients who have osteochondral lesions who have failed conservative management, but they're not quite ready yet to jump in and do operative management, or patients with labral pathology in the hip or in the shoulder. I think those are all really exciting areas that I think would be interesting, but again, it's really difficult to do some of these invasive studies in the younger pediatric population, and also just not a lot of data out there looking at the younger population.
Yeah, I certainly agree.
Yeah, I just had a question about the PRP as well. I understand the kind of the physiology behind doing it for like a chronic degenerative tendinopathy situation. It's my understanding you're trying to jumpstart the healing process again with the blood products that control tissue turnover and that kind of thing. I guess I'm surprised to hear that it's being used in acute situations, and I had two questions. I think when you inject it into an acute injury area, are they injecting it right into the acute area? That's one question. And then the second question is there required immobility afterwards? And if so, what's that protocol? And then how does that work with physical therapy if they're attending physical therapy at the same time?
So there is no protocol that's standardized for PRP injections. There's a gap in what's the best volume to use, the frequency, like Dr. Ellis was asking, 1 or 2 or multiple injection, and the timing in between if you do get multiple injections. So there really is no protocol. Acute injuries, yes, from hamstring injuries are the most commonly used acute muscle injury out in literature. I think mainly because it is one of the most common injuries that athletes do suffer from, and it causes significant time loss from sports. Some of my prior partners were doing it a lot in our collegiate athletes who had acute hamstring injuries. You inject the PRP directly into the region of injury, okay? So whether it's like a proximal, if it's a high hamstring strain kind of up by the ischial tuberosity, then, you'll just inject it, right below in that muscle tendon region. And my partners used to kind of pepper it around in that area when they would inject it in. I think different people have different techniques, but they just kind of pepper it around in that area. There really is no downtime, except we say take it easy for the next 24 to 48 hours. Don't go into aggressive sprint or intense aerobic workouts. Just take it easy, but they don't need to leave the office in crutches or anything like that. Yeah, and obviously you counsel for look out for any signs of infection, things like that, because it is a procedure that you did receive. So. Yeah, but there really is no protocol out there telling us, the best amount of volume to inject, the best frequency and the best technique. There really is no good protocol out there. Yeah.
I just have a question. We had a physician that came to our practice and had talked about the difference in sometimes there's a kit, I guess, that physicians will use. And then they had a lab themselves, and they showed a difference in the number of platelet-rich plasma, and they were saying, well, ours is better because it has a higher volume. So is that true, or how do you differentiate between one practice to another and the standards that they use in administering it?
Yeah, so there are a handful of PRP companies that make the centrifuge, and it does come in a kit. Harvest is one of the big companies that just comes to the top of my mind. And so the rep will bring a centrifuge that you place in your office. You can either, a lot of the physicians have a nurse or someone, draw the blood from the patient. You spin it down in a centrifuge machine for a minute or so. And then the PRP usually kind of floats up at the top. So you just aspirate that. And then there is some type of solution that you kind of mix it into typically, and you inject it. There are various companies out there, and of course all of them claim that theirs is better because their centrifuge machine, does it at a higher speed and it's able to extrapolate more platelets and things like that. Again, from the literature search and the research that I've done, there really isn't anything that shows that, one is better than the other. Yeah, I don't know if that answers your question, yeah.
Yeah, Grady, I think that's a great question, and the big criticism on PRP right now in the research is that the variability amongst all the about all the companies that are spinning it and all the sets that they use. But the reality is more better. Having a higher concentration of platelets or a less concentration of your WBCs. I mean, I don't know if we really know all that stuff is better. I'm not sure we know any of that information because the science is very unclear and limited, and so I think. The way I look at it is, it's maybe better than doing nothing, but I'm not sure the value of it. I'm not sure one company over another one in terms of its, what it's telling me its numbers of platelets is going to change my view. Right now, it's also a business. It's a cost issue. So, and that's an important consideration, right? Because some companies are 3 times the cost of other companies because they think theirs is better, but I don't know if that's true or not. But I think it's a great question. Yeah,
and I think, it's like Dr. Ellis said, there's not a lot of research out there in the pediatric population particularly, but hey, if it's, one last thing that they want to try before, surgery's, the final option, then, from the research that, is out there, it doesn't seem to be harmful from what we know. It doesn't have any negative adverse effects. And so, it may perhaps, alleviate some of their symptoms, such as pain temporarily. So, may not hurt to try, but there, really isn't any strong grounded evidence of, its long-term effects or benefits. Yeah.
Want to do it prior to therapy? At what point would you do one or the other or both? And then what kind of acute window are you looking to administer the PRP? I mean, like how long of a time frame?
Right, great question. So all the research has combined PRP with intense rehab program. And so I think one known fact that's clear out in literature is that you want to always combine it with an intense rehab program. And, the studies have shown that, a lot of most of the athletes do just as well with just an intense rehab program alone. So if they're going to get PRP, I would always say still combine it with an acute, within a good intense rehab program. In terms of the acuity of it, in the literature that's out there, they try to capture those patients within a week or so from the acute injury. And many of them, also confirm the diagnosis using ultrasound or MRI. But it seems to be like from the studies that are out there, acute meaning within 7 days of the injury is what I'm seeing out there in literature. Yeah. Yes.
When you're looking at the BFR, the blood flow restriction, what is really the main idea behind this? I mean, is it really to try and push as much blood into the specific area as possible and heal it that way, or is it to try and trap as much of the oxygenated blood into the muscle?
Yeah, great question. So the pneumatic cuff is there to partially restrict venous outflow from that muscle, right? So if you're working on the knee, the cuff would be around the quad area, and you pump up the pneumatic cuff and you want, so the idea behind it is to partially occlude venous outflow from that muscle, so to kind of keep it in there, so to say, and to partially also keep some of the arterial blood flow from coming in as well too. So that's kind of the idea behind it, and to, I guess if you want to think about trying to capture a lot of the oxygenated cells in that area and to kind of concentrate it in that region is maybe some, yeah, kind of a way to think about it. Yeah. Any other questions? Yes. It's okay. I think John's got a new mic for you.
Is there any evidence on acute musculoskeletal injury rates in HIIT training versus continuous steady state training, and is this different in kids and adults?
So if I'm understanding correctly, is there any evidence out there for injuries with HIIT training?
Yes. Is there a higher incidence of that with HIIT training than in just continuous endurance type training?
Not that I've seen anything out in literature, yeah. And none out for pediatric population, but even for the adult population, I haven't seen any literature saying that there is an increased risk of injury. And I think the reason, and I don't, my personal opinion is I don't know that there would be necessarily an increased risk of injury, because when you're doing the HIIT training, you're already warmed up, right? So during your rest period, 4 to 5 minutes, you're not just stationary and not doing anything. You're continuously moving your muscles are staying warm, the blood is flowing, and then you're doing these acute brief bouts of intense sprinting or whatnot. And so I don't think necessarily that there would be an increased risk, but I'm not sure. Literature might say otherwise, but I don't see anything published out there as of now. Yeah, great question.
Dr. Chung, can you speak to the training for this? Is this like a certification program? Is it a see one, do one? How's the training for this go? Do you know much about that?
Yeah, so there are, you can take obviously high intensity interval training classes, like gyms will offer it, personal trainers and things like that. I do it on my own at the gym. I just, like the 7-minute workout I showed you, I do that when I go to the gym. I do that twice a week, actually. And it's easy to follow. And I think if you have a base, aerobic fitness, I think you can, and the great thing about it is you can cater it, right? And so if you want to be on the treadmill and you only have 20 minutes to work out because you've got to, get to clinic or whatnot, you can, cater any of it. And some of the common regimens, like the 1-to-1 ratio is common, where you work for 1 minute and you recover for 1 minute, 3-to-1, or you can do like a 1-to-2. And so there really is no rule, but there are some common programs that you can kind of try on your own and see, if you like it. But you don't need, I think, to teach a high intensity interval training program, you may need a certification, but you can definitely incorporate it part of your workouts. And again, it's time efficient. It is shown to increase muscle mass and, decrease fat and things like that. And also, has benefits of, increased calorie burned due to the excess post-exercise oxygen consumption. And so I think it's something that you don't want to do too frequently because it does require a longer recovery time, but it's great in that you can kind of cater it on your own. And again, these are just guidelines, right? And so if you want to only do yours for, 5 to 7 minutes, like you're on the treadmill and you want to just sprint for 30 seconds to a minute and then kind of, scroll your pace back down on the treadmill to like at a walking speed of 3.5 and do that for 10 sets. I think that's good too, but we know that the brief bouts of increasing heart rate and things like that have been shown to be beneficial even from a cardiovascular standpoint from what research is showing us. So yeah.
There are many therapists that are here with us today. How many of you guys are doing BFR treatments in your clinic? I find it's really kind of picked up quite a bit. I thought some of the data is pretty compelling. surgeons for your post-operative patients, or is it something where you guys wait until a certain post-operative period and you feel pretty comfortable that it's the right thing to do?
We usually work in collaboration, but I mean, you can use the BFR as soon as they come into your clinic. I mean, we give them information and educate them and really leave the decision up to them, but leave it as an option, a viable option for recovery.
And what patients do you typically use it for in your practice?
Well, we have used it on some adolescents. So it,
All right. So we just use it on various patients. So the youngest, it's probably middle school. I think we have a 12-year-old patient that this is probably the youngest so far. But we use it all the way up to, I think, 70s, 80s. It really just varies. But there's been, so musculoskeletal diagnoses, but we also use it for neuromuscular and miscellaneous. So we had a polio patient that used it, a patient of mine, she had scleroderma, and so just trying to get that atrophy hopefully back, or at least some strength components back. But they come out with more and more information and education as far as research goes about the benefits or applications of the use. So it's really, we started off with just musculoskeletal, but we've really broadened our use of it.
That's fantastic.
like, how long does it last and how frequently do y'all have like a
Um,
I would imagine that you could probably go wrong.
You could. So you have to go through it. So the system that we use is Adelphi. So you have to be certified to use it, and then to even purchase the unit, you have to go through their certification process. There is certain steps or frequency of use and how often you use it. It really just depends on the patient, but you could use it. Usually we start off with just like with one exercise, and you want to do it at the end of the session just because it really makes you tired. But you can also use it, I mean, you could use it with multiple exercises. I mean, with professional athletes, they've showed that they use it like at least twice a day. I mean, that would be very intense. I mean, even one use, one exercise, some people go home and they're like, I was exhausted, I just went right to sleep. So, I mean, that's mostly the, I guess, drawback is just the fatigue. But other than that,
Yeah, I think it's, from all the data I've seen, I think it's, valuable, and I don't see any contraindications in the postoperative period, but I frequently have therapists call and ask, do you mind if I do this? And I'm like, oh, yeah, of course. But I didn't know if there was any other pushbacks from any other surgeons that you guys have received, or if it's been pretty collaborative.
pretty collaborative. If they didn't know about it, we just give them more information, and they're pretty
Great.
accepting.
Great.
Fantastic.
Well, I'd like to give Dr. Chung one more round of applause.